I'm Dan Hawkins with NAC, and we're here with the Health Center History Project with Grace Wang, who is a clinic physician at International Community Health Services, ICHS, otherwise known as the International District Clinic, right?
So
or used to be.
It started with one clinic in the International District, which is Seattle's Chinatown. But there's actually more sites now.
Yeah. So thus the moniker ICHS.
Correct.
That's great. So tell me about what drew you to health centers in the first place, and what was the motivation you had in going to work with health centers from the very beginning?
Well, the very beginning is actually before I went to medical school. And I think it had to do with being in a place where everyone could be treated on an equal footing. I started out actually at a health center doing a health careers program before medical school. And the people who were paid staff, like myself, were the ones who staffed what were then volunteer clinic sessions. My job actually was to make sure the volunteers got fed, because they were giving of their time. Most of them had other full-time jobs, and they would come after their long days of work.
It was all volunteer work, huh?
At the time, it was all volunteer, because those were the days before the Health Center at 330 funding. So that was how I first found out about health centers. But I think why health center work has sort of become what I've done most of all of my professional career is probably because of things my parents taught me. They were very religious people who really taught me things about how I should be in this world, treating people as I wanted to be treated, and this notion that everybody is loved and of value. And those were really actually became easy things to follow in a health center.
So your educational path.
So I started out thinking that I was going to actually major in math. I don't know how that happened, but that I quickly learned the error of my ways, and became very interested in, and still am actually, in child development. So I ended up getting a degree in education, and with that, got to be involved in a couple of different things that I think, not realizing at the time I was learning some really important lessons. So one was I became involved with a cooperative preschool in Ann Arbor, and sort of saw how the community made active decisions and actually operationalized them in how they wanted their children to be cared for and taught. And then one of my student teaching experiences was in Inkster, Michigan, which, if you're not familiar, is a bit outside of Detroit, and an area where many people who were from Appalachia came to work in the car industry.
The auto plants, huh?
Yeah, and I had an advisor, lovely African-American woman, Gwendolyn Baker, who went on to do amazing things in the not-for-profit world, who was responsible for having students do their student teaching in that environment. So it involved a commute from Ann Arbor, obviously. And the people who chose to do their student teaching out there, of course, were people who did it of their own choosing. So we were a little bit different. And the person who I was placed with at the time was someone who was a bit older, had done other things in his life, and really embraced this idea that, that education was what lifted everyone up, and we should make every opportunity we had to be to help to contribute to that process. And it ranged from being the best teachers we could be to doing things like making like a 3-story gingerbread house at Christmas time that we transported by car from Ann Arbor to the school. But that was exactly the kids' expression. It was a wow. And for some reason, those kinds of things stuck with me about how you can be in the world and how it can have an important impact for both the person like me, as well as what you were trying to do. So those became sort of important things to look for in what I did going forward.
But at some point, you decided to change direction and
Yeah,
pursue medical education.
Well, believe it or not, when I graduated from college, I know it's hard to believe, but in those days, there were actually too many teachers. And this idea of early childhood education was actually not getting the traction that it is now, where there's clearly evidence about early brain development and how important it is. So I did a year-long internship with a family therapy not-for-profit in New York City. And my job was to work with the families who were in family therapy when the children were identified as having school issues. And so I had a couple of families that I worked with. And I think those experience sort of, I was raised in, very comfortable surroundings, and I knew that there was something different out there, and then to see how people were living in New York City this would have been in the 1970s. It was appalling to me that in this day and age that there was such inequity. And one of the families I work with, I remember I used to take their daughter home after school because I would help her with stuff. And it involved taking the elevator train and then walking up this series of stairs, up this like steep hill. And then I would get to their apartment and all of the electricity was through an extension cord that was plugged into the light fixture in the hallway. And they weren't the only one. And that said to me, there were just things, I guess I was kind of young at that point, but there were just things that weren't right, and I needed to be able to do something about that.
Yeah.
So.
Now that was in New York.
Yeah.
Is that where you were born?
Yeah, across the street
Wow.
from Gracie Mansion. But that's not the reason why I have my name. It was just where the hospital was.
Okay. You went to Michigan for undergrad school. At what point did you make a decision to pursue a medical education?
I think when I was recognizing that I wanted to be in a position to do something about these inequities that I had witnessed. And, both my parents had been trained as docs, but my dad had been more of a specialist. He was an anesthesiologist, and my mom hadn't practiced once she started having a family. So my notion of how you actually do this in medicine wasn't that clear, but it did seem to me that if you could take, so I don't really remember the full line of reason, but I think it was something along the lines of if you could take care of everybody who needed health care, then that was one way that you could make things equal. So that was kind of my decision.
At least regardless of what their economic circumstances were, right?
Right. Everybody should have good health, and I could be a healthcare provider.
You could do that.
Yeah.
And so you went to school where? Medical school?
So at the time it was called Cornell, and now it's called Weill Cornell because certain people gave a certain amount of money.
Upstate New York.
No, actually, Cornell Medical School is in New York. It's in Manhattan. Yeah.
Okay.
On the east side.
All right. And while you were there, my understanding is or maybe it was later on, you had a National Health Service Corps scholarship.
My medical education was supported by the National Service Corps, and it made perfect sense to me because what it was supporting people to do was what I envisioned after being in a health center, what I wanted to do. So it made perfect sense, although as with everything that is subject to the political leanings of the time, by the time I could fulfill my obligation, where they were sending people had changed. And so I knew that what I had trained for was urban family medicine. And I don't know if you know this about me, but I'm kind of stubborn. So I said, I'm not going to do something that I'm not trained to do. And so
They wanted to send you to some rural community?
I had to follow my odometer from a gas station, which is, no, I'm not meaning to be disparaging in saying that, but that was not the type of environment where I've been trained to practice, nor did I think as a woman of color it was necessarily the environment where I could see
Fulfill
myself.
your dreams, yeah.
So I was very lucky. What was then the Chinatown Health Clinic did their piece for advocacy, and so I ended up serving my obligation there with a penalty, but it was what I was supposed to be doing anyway. So
This was Chinatown in New York City.
correct.
And what did you find when you first got to the health center in terms of the patients there? What were their needs? What were you being asked to do to provide care for them? What kind of care? And what did you notice? I mean, you talked about inequities. You must have come face to face with some pretty severe inequities in the economics, in the insurance coverage, in the health status of the folks you were serving. How did you confront that, and how did you respond to it or react to it?
So the health center served a large number of folks who worked in garment factories and restaurants. And these were people who were working at least 6 days a week, and very, very difficult working environments. And their children were in this new environment where the parents had no experience with navigating, and that's where the health center played such an important role.
Now, you were providing, was it a pediatric residency? Was it just a general internship?
I did family medicine.
You did family medicine, okay.
And I did family medicine at a program that a number of giants in our movement have had a role. Merle Cunningham.
Oh, sure.
So we were well trained to work.
Ed
in
Martin,
health
as I remember.
Yeah, he was.
He was before you.
Yeah, and he figured heavily in my National Health Service Corps story too. But it's all good, and it turned out to be a wonderful life story. So we were at the health center. We were open 7 days a week, and I actually worked the Sundays. And we would see families that would be their day off. They would come to Chinatown to do their shopping, and then they would be in to see us, and we could help out with the usual things: health maintenance, diabetes, hypertension. One of the things that was sort of a big piece of what the health center did was health education in the community, and there were these subscription radio stations. It's sort of like cable TV, except it's radio, right? So you pay a subscription, and then you get this box, and it's tuned to one frequency, and that was the Chinese language radio station. And the health center had a very robust health education program, which I believe they do to this day. And so the people who were coming to see us knew of the health center because of the education that they would hear, because the employers would subscribe to this, and that would be sort of the background noise, if you will, of where people were
As
working.
they were working, huh?
Yeah. And so that kind of holistic approach really was meaningful and really made sense. And early on, this was actually before I went to medical school, while the health center, in the days before it had the health center funding, would do fundraisers through this radio. They would be called radiothons.
Mm-hmm.
And it was typical that the factory workers would challenge the boss to match what they collected amongst themselves. And I remember my brother was your typical, American-raised child of immigrants, so he was big, right? And when we needed to go collect what was mostly cash, we needed big people to go and do it. And so my brother actually was one of the people that went out and did it. And they would come back with these envelopes of cash, and it was because the people who worked in the garment factories recognized the health center from the information that they listened to every day while they were at work. And when they heard that this place that was bringing them this information needed help, they responded in ways
Generously
that,
gave,
to this
huh?
day, I mean, that was probably one of the most meaningful things that I saw. And then, of course, to have my family involved in something that was meaningful for me.
Your brother was the enforcer?
My brother was this big, he still is a big Chinese guy, and they wanted big people to go and get the cash. So I brought my brother into doing it. And
You side by side with him going?
No. He would go by himself, because I think, kind of having your much shorter. Actually, I'm older than him, but your much shorter sister with you kind of like dilutes the message of I'm a big guy here to get your cash. So, anyway.
So, but in those days before the federal grant, I assume that the health center relied heavily on the donations they collected
Absolutely. Sorry,
in order
I'm
to
just gonna-
support their service.
I'm just going to get out a tissue. That's okay. Absolutely. Those, and so not only was it meaningful for the numbers of people that participated, but also for the fact that that was the way the health center was
Survived,
able to
huh?
keep on going with its program.
Were you there when they were funded finally by the federal government as a community health center, or had you moved on by then?
I think it took place while I was in medical school.
Aha.
So yeah. So in between when I went to medical school, did my residency, and had to navigate my way through the core stuff.
But you were coming back home.
Yeah, so I
with some
came back in
regularity.
1989. Yeah,
Okay.
11 years later.
Wow. Your residency was completed where?
In the Bronx.
In the Bronx.
In the Bronx. I did my continuity clinic, so the outpatient port, in what is now an FQHC as well. So
Again, in the Bronx.
in the Bronx, yeah.
What in God's name? So I'm trying to follow your pathway ultimately to Seattle. We still haven't left the Bronx or Michigan yet.
Well, sort of. No, because after I finished residency, my first job actually was in one of the neighborhood family care centers run by the Health and Hospitals Corporation. That was also just about a half a mile from Yankee Stadium. But nonetheless, the way the South Bronx and those days outside of Yankee Stadium, it was still a very different place than it is now.
Sure.
In terms of with the building of the highways and what they did to the neighborhoods, having sort of cut them up. And,
Yeah, that's been through there, so I understand exactly what you're
although
talking
it's
about.
some interesting things have happened. It looks a bit different these days when I've
From what they were like when you were there?
yeah 40 years ago. Yeah.
Yeah. A lot can change in 40 years, yeah.
Yeah. So then I did what was supposed to be a managed Medicaid pilot for a couple of years, but then ended up going back to Chinatown Health Clinic. And then while I was there, I realized that, I learned how to be a doctor one-on-one, but what I hadn't learned very well was how to do things that involved more than one person at a time. So I went back to Michigan and got a master's in public health in the
You did?
on-job on-campus program, which you recall was actually, I believe, started to train health center leaders.
Yeah,
Yeah. So
I do remember that.
and that was a very useful time of learning for me because one, it gave names to things that I thought I was doing flying by the seat of my pants, and then it also taught me some really useful skills, and that was kind of the trajectory that started with me ending up in Seattle. I worked so after I got my master's in public health, I had an opportunity to actually work in the Bureau of TB Control for the New York City Department of Health, which in the 90s, tuberculosis was a real problem because we had come from a time when public health funding had not been there, and consequently, for a variety of reasons, we had, unfortunately, multiple drug-resistant tuberculosis, which which was very challenging. And fortunately, CDC stepped up and gave New York City a huge influx of resources. And so I was there at a time when uncharacteristically public health had a huge amount of resources to work with, and they literally went to the streets, and that's how they combated the TB epidemic. And every quarter, the bureau chief would review in every borough. New York has 5 boroughs, and he wouldn't sit in his office, he would go to those boroughs, and he would review every single active case in that. And it wasn't just the identified patient, it was, and how were all the contacts tested, and what happened. It was really fascinating to be part of public health on the ground.
This is sort of classic population health, but focused on individuals and the conditions they have.
And their families and the community.
Sure.
So it was, but I found that I actually missed primary care in doing that. I think I mentioned, these drugs that could treat multiple drug-resistant tuberculosis were not without their side effects, and so it was really important, particularly for women of childbearing age, to be on appropriate and safe contraception. And in the public health setting, where I knew how to do both the treatment and the managing of other primary health-related conditions, all I could do was the public health part. So I missed, it didn't feel right to say, well, you need to make sure that somebody gives you a prescription for some form of contraception when I was trained and actually licensed to be able to do that.
It wasn't really whole person care.
No, not at all. So I missed that, and then I had the opportunity, I was recruited to be the medical director of the health department in Seattle and King County, which is an FQHC because they have a healthcare for the homeless program.
Right.
And at the time, actually, had a number of primary care practices. So I thought this could be the ideal combination. And off I went across the country.
Seattle and King County have been one of the most progressive, both public and personal health domains.
Yeah, it's
but anywhere in the country.
Very, yeah.
On that. So you were fortunate to be there. And What would you say you learned from that experience that you apply even today at ICHS?
So what I see ICHS doing is looking at it from a community and population perspective, so that while my colleagues who are providers are very well trained, because for some of them we train them to provide good care, we also have people on our teams who have the ability to know our communities in ways that, as medical providers, unfortunately, we're not trained to do that very well. And so, there are folks at each of the sites within the organization whose sole job is to interact with the community. And that very much helps to inform what we do as clinicians. And that, to me, is a really important piece of why I continue to be a health center clinician.
You can see the mixing of the personal and the population-based and the community-based focus on healthcare.
Absolutely.
From the health center. Is there any place else out there in your experience that's doing that with any success?
Well, actually, locally, our partner organizations in the area do a great job in those areas. The things that come to mind are, Health Point has their, what's it called? I'm blocking on it. It's something to local. But they have a program.
Well, they're a community health center.
Correct. We also have Neighbor Care, which has a healthcare for the homeless program in our area. We have Country Doctor.
Another community health center.
And then in our mix in our area, we have CMAR, which is not only in our area but up and down the I-5 corridor into Oregon, and we also have the Seattle Indian Health Board, which and I think all of them have programming which looks at the communities that we're in and then says, in addition to good health care, these are other things that we have a responsibility to do to make sure that the communities that we serve are getting the care that they need. And it's not just health care.
But of all of the partners you've mentioned, and they all have their own specific both geographic area that they serve or population group they serve, none is as focused on the Asian Pacific community as ICHS.
That's correct.
And that's what you bring to this, this partnership on this, even though I'm sure Health Point and Family Doctor and the others serve Asian Pacific Islanders among its patient population. You are still the sort of provider of choice.
That is correct.
For the Asian Pacific community. Are you able to lend some perspective or expertise to those other partners on serving Asian Pacific Islanders, not just linguistically, but culturally, health focus, et cetera?
Yeah, I actually just this past week, I was having an email exchange with the medical director of another health center area about caring for patients with hepatitis B. So that is an issue where I'll tell you, I didn't come to the health center knowing what I know about it now. It's actually been an area of learning for me. But it is something that, because of where our patients come from, it's really important. And in the communities that we serve, Seattle, I'm sure you've seen this elsewhere around the country, as people get priced out of being able to access affordable housing, they move
Sure.
further outside of the city, and that's happening with us. And so actually my practice site is more in the southern part of the city, and that's, where we're seeing a lot of change because of the lack of affordable housing in the city proper happen. But it's also an area where, because historically there was an effort made to make sure that there was access to affordable housing. So in addition to seeing the population that the health center has traditionally seen, which are Asian Pacific Islanders, actually in my practice, I have a fair number of folks who are like from Horn of Africa countries. And that's also an area in the world that also has higher rates of hepatitis B infection. So it's not, it's having expertise that can also be used because of the population that we've served, to help not only in what is considered our niche area of expertise, but more broadly.
Now, earlier on, you mentioned training and education. So what is ICHS's involvement in clinical and non-clinical education and training today?
I think the list of what we're not doing would probably be shorter than the list of what we're doing. And I've not been in the C-suite for a number of years, so I'm most familiar what's happening around medical provider training.
Okay.
The health center, as of yet, is not a recipient of Teaching Health Center dollars, but was one of the early adopters with respect to nurse practitioner residency training, and had the good fortune to become ACJME approved continuity site for a local hospital-based family medicine residency program that has like a double digit and above 50%, I believe, of its graduates working in the health center world and with the underserved.
Wow.
It's a phenomenal.
It's a great success story.
It's a great program, and their continuity sites, with the exception of the hospital-based sites, are all either FQHCs or Indian Health Service sites, and it's great.
They are training the clinicians of tomorrow.
Yeah, and that's
vitally important.
And when I was a medical director in CMO, I mean, I have to say, I think the things related to personnel were probably my least favorite things to do. It was, Dan, it was so hard to recruit people. It was so hard. And, as a practicing clinician, I could see the need, I could feel the need, and here would be people who, they didn't see health centers the way I did, and it was really hard. And then once the health center started training our own, they're lining up to apply for slots to train, and then
staying?
Most of them want to, over 50% of them want to stay.
Wow.
And then the reasons they leave are, I'm not saying every single person stays, but the ones, the number of people who apply for the limited number of slots that there are never ceases to amaze me.
You got a waiting list, huh? At every point.
Well, you have to say no, I think.
Yeah.
But all of the teaching stuff happened sort of towards the end of my career in the C-suite, and gosh, I wish I had done that way, way earlier. I would have had a lot less gray hair. It's real, but that's actually been one of the most rewarding things to see. This year, the health center graduated its first class of family medicine residents who did all of their training at the health center. And we're 2 each year. So one of them is staying. One of them had to leave because her fiance is training elsewhere out of state. But it's wonderful.
Man, that's great.
Yeah.
I mean, that is the future, I think. And that, speaking of the future, your perspective on health centers' role in the world of healthcare today and the future for health centers. in the US?
So I would predict that 50 years from now, we're still going to be here. But I think what we're doing is going to be different than what we're doing now.
In what way?
Well, I think when I look at what are the forces that are shaping the lives of our communities, both positive and negative, these are areas where health centers, if not already, need to be leaders. And I think about the sort of marriage, if you will, of primary care and public health. I think of using the voice that we have in advocacy on behalf of issues that impact the health and well-being of our communities. And those are very much ingrained in very strategic ways in what we do as health centers. And those are the things that I think we need to do more of and be the leaders, because I think that's going to be the secret sauce to having a healthy country.
You think we need to speak up more? For example, the public charge issue that's so hot right now in immigration. From your perspective, is the health center leadership leading the charge on this? Or
Absolutely,
doing enough?
absolutely. I mean, traveling yesterday, I was going through the emails that, you have to turn your phone off on the plane, theoretically, right? And when I turn, so I'm still one of those people that turns their phone off. And, there was a email from the CEO about what action, this went to the entire staff, on what action we should take around this issue of public charge. And those are examples of where, as health centers, and I'm not saying we're the only ones out there, I mean, definitely we need to be doing it in partnership with the legal community. And I think there are, many others in our community who have the same concerns as we do, but I think health centers need to be out there taking a leadership role.
Raising hell. We need to raise some hell, don't we?
We need to do our job.
Yeah, there you go. That's what's expected of us. It's representing the community.
Right, and it's the health and well-being of the community. That, to me, is why we need community health centers.
There you go. Wonderful. Thank you so much, Grace Wang. Thank you for everything you do. Thank you for your daily work, and thank you for your leadership within NAC as well.
It's a joy.